Hi, I'm Professor Charles Knowles. I'm Professor of Surgery at Queen Mary University London and a colorectal surgeon at the Cleveland Clinic London. My role in the AMELIE project is I'm the Clinical Chief Investigator. At the moment, I probably see about a patient a week with faecal incontinence, in whom a sphincter injury is at least part of the problem, and in some of those it's most of the problem. I see other patients with incontinence by other causes, and of course other people with bowel dysfunction, but about one a week I'm guessing at the moment, so it's not uncommon. So the most common cause of a sphincter injury is childbirth in women, and by far. But there are other causes, and those causes can affect men and women. I'm afraid that as surgeons we're guilty of causing some of those problems. So surgery for other anal diseases like hemorrhoids, fissure and anal fistula, some of those surgeries can result in incontinence. There are blunt trauma, sharp trauma. I treated, for instance, one of the patients from the London bridge attacks who had been hit by a car and her sphincter injured after a terrorist attack. So there's a number of different causes, but by far the commonest are childbirth, what we call obstetric anal sphincter injuries, or OASIS for short. Well, we know that the mental health impact of fecal incontinence is severe. One of the worst things you can have. So papers have been written on this subject, books have been written on the subject. An example of that would be the paper in the Journal of the American Medical Association, which showed that incontinence in generality, but particularly fecal incontinence, is one of the most feared conditions. Feared in many ways more than death in hospitalised patients, feared more than cognitive impairment, feared more than immobility. And that's because incontinence can affect your daily life in all manner of ways, from the ability to work, the ability to socialise, the ability to have intimate relationships, and it's a well-recognised cause of depression, anxiety, other mental health disturbances and a reduced quality of life. So patients with fecal incontinence from an obstetric anal sphincter injury, to be clear, represent one group of fecal incontinence, an important group. And one of the difficulties of treating this is that we have historically not approached this in the right way. So the obvious thing is that there is a gap in the muscle of the anal sphincter caused by tearing, in effect, and that we should repair it, which makes perfect sense. And indeed it's what we have done for 50 years as a primary treatment of what's called an overlapping anal sphincter repair or an anal sphincteroplasty. The problem is it doesn't work like that. So the control of continence is not really controlled by a barrier. It's a nice idea. It's a nice idea that it's a pipe and that by blocking the bottom end we'll stop the problem, but that's not how it works. How it does work is that the rectum rather than the anus is the primary controller of continence, and that's because nothing comes out of the rectum without the rectum squeezing it out. It's a fact of you have to push normally and the rectum has to contract. So it's the control of the rectum that's actually key to continence. The thing is though that the anal sphincter is not divorced completely from that, because the two are connected by the nervous system in quite a complicated way. So repairing the anal sphincter, or at least restoring the function of the anal sphincter, is still important to the control of continence because it secondarily affects the rectum. And this is where we've gone wrong, because what we need to be looking is restoring the function of the anal sphincter, not anatomically just pulling it together. And in fact, constricting it, and anyone could sew the anal sphincter together, is counterproductive, because it actually harms that elaborate system of control of the rectum more than it benefits it. And so, looking to the future, to the unmet need that we have, and there is an unmet need, we have to look at treatments that restore function, which in reality are neuromodulation, that's electrical stimulation of the nervous system to restore control, and cell therapies as it currently stands. So the AMELIE proposal and the intervention we're going to use is not only innovative, it's unique. I mean, no one has done it before. So the principle of AMELIE is that we are taking native cells from one part of the body, from a muscle, and we are growing those cells and in a way rejuvenating them, binding them or anchoring them to these microspheres, the tiny beads, and then injecting that mixture back into the anal sphincter. Now, this is important because we know from studies, a whole variety of studies over more than a decade, that if you take muscle cells that are not anchored, and we have, and they have an effect, and there are several studies, including those that I've been involved in Europe and in the United States, that show the benefit of cells alone. But if you take them on their own, basically they don't like being, our muscle cells are anchored at all times when they're in our muscles, they're pulled out. And if they're floating around, just unattached to things, that causes a proportion of them to die. So when we want to graft these into the anal sphincter, we want to anchor them so they all, or at least most of them, survive long enough so that they can bind in with our natural cells to improve function. But this returns me to an earlier question, because the importance of this is not that we believe these cells will form a bigger sphincter or close the hole, as it were. It's because we believe the action of bringing new, refreshed cells into the area in a functional state affects the other cells that are there to restore function, not only probably of the muscle, but also of the nerves that interact with the muscle. All of this compares with what we have at the moment. So I've mentioned earlier neuromodulation, the electrical stimulation of the nervous system. It's a good treatment. It's the gold standard surgical treatment, sacral neuromodulation in particular. But it involves having an implant put in. You have to carry a card at airports, you have to turn it off when you're driving, you have to charge it in some iterations, you have to have the battery changed. It's a lifelong contract between the patient and their surgeon like me, and it has a high cost. Other treatments, we're into pads, we're into bulking agents which have very poor efficacy. Pads, of course, are deeply unattractive, or we're back where we've been a long time with a colostomy bag. And I should say that a colostomy bag has relevance to a group of patients with severe incontinence, who are severely limited, and it can be a very good treatment, but it's not what most people want, particularly if you're young. So that's really where we are with treatments, and AMELIE being added into that landscape, we hope will change that paradigm. So the stage that the AMELIE project is at the moment is about just over halfway through the whole programme. So when the EU funded the AMELIE project, they were funding several work packages that took us from the small microspheres, the beads, and the cells through to the clinical trial that we're proposing in humans. And there are many stages before we get to the clinical trial in humans. Those are stages that require the safety of this to be tested, to work out how we bind the cells to the microspheres in a way that they don't fall off or cause a safety risk. And all of those things have got to be scalable in a way that we can prepare this so in a consistent way and then ship a patient's product to wherever they are in Europe so that it can be used, and there are all the transport issues with that and everything else. So it's a big piece of work, of which the clinical trial that we hope to start in late 2023 this year can get started. So we're now at the stage of preparing the documentation for that trial. That has to go through the regulators in several countries to demonstrate its safety, to be approved. like any new treatment, so patients can be assured that they're having a safe treatment even though it's a research intervention. That paperwork is not a small job, as I'm sure many people can imagine, and when all of that is done and we have the rest of the results of the preclinical data, the pre-human data, then we hope to proceed with recruiting patients to the trial. My hopes for the AMELIE project are really first that we can successfully complete it, that we can recruit the patients, and that we can complete the trial in the way that we want to. And it's a big trial, and it's across a number of countries, and there are a number of barriers to successfully doing that. After that, I hope that it's safe and that we don't have any adverse events from it. I don't think we will. My belief is that this treatment, having used cells before individually and microspheres individually, will be completely safe, but that's part of what we will find out in the trial. After that, I hope we get a definitive result. Now, when people do trials, you can get a result one way or the other, but what you don't want is to not get a result at all. I don't mind finding that it doesn't work. What I want to know is whether it does or doesn't work. And even if it doesn't work as well as we wanted it to do, that moves the field on, because it tells us what we don't want to do in the future, and very often it's the first step of informing some modification that's required to make it work. I used to work with Professor David Wingate, who was a gastroenterologist here, and he said a hypothesis is like an old car. It may break down, but it will get you some of the way. And there's a great deal of truth in that. If AMELIE gets us some of the way, it will be a big step forward in the field. Of course, ultimately what I really hope is that we will get a positive result with the exact form and the way we're doing things. Then that can go to what we call a pivotal trial. That's a much larger trial done with a slightly different design, which would see its road to market worldwide. For me, the most exciting aspect of the AMELIE project is bringing together the greatest and the good from Europe. I mean, we have in this trial everyone, in fact, who has any experience of using cell therapies for fecal incontinence are involved in this trial. So that's great, but obviously my overriding dream is that it works for patients. I mean, that's what we're all here for.